It looks like some folks are still trickling in.
Hello, everyone.
Hello.
Hope you can. Oh, good. I'm connected. Yay.
Hi, Ellen. How are you?
Hi, everyone.
Hi.
Hi.
All right, Kelly, you want to get started?
Sure. Good afternoon. Welcome and thank you for joining the first meeting of the Interstate Telehealth Workgroup. My name is Kelly Scott and I'm a program manager here at the Maryland Healthcare Commission. I want to start out by saying this meeting is being recorded. Meeting materials can be found on the Interstate Telehealth Workgroup webpage on MHCC's website. A link to that webpage was included in the email I sent this morning, and all meeting materials and recordings will be posted there. At this time, I'd like to invite MHCC's director, Ben Steffen, to make opening remarks if he's logged on. Ben, are you here?
I am here. So thank you, Kelly. I want to welcome all of the participants. I also want to remind the work group participants that we did release a report last month focusing on recommendations related to continuation of the telehealth waivers that were established as a result of the public health emergency in 2020. This particular work takes us in a little bit different direction, and I think it recognizes the reality that how telehealth is going to fit into the overall framework of care delivery in Maryland going forward. We know that during the pandemic, many practices fully or nearly fully implemented telehealth capabilities, especially among specialists. That has dropped off significantly. We've also seen the growth of multiple telehealth platforms that serve Maryland patients. Some of those providers are operating outside the state, but with Maryland license. And I think this work really really focuses on how telehealth is going to evolve as a model. Is it a component of services all practices deliver, or will it be a feature of the healthcare system where some specialization or a great deal of specialization takes place? Our role is to make recommendations to the legislature on the pathway forward. So I appreciate the work group's attention today and the meetings going forward. And also want to welcome our consultants from Westat to this endeavor. We were most impressed with the proposal submitted, and I know the conversations that have gone on between Westat and the staff have been most productive. We look forward to a very productive work group, and if there's any questions folks have that may be appropriately directed to me, feel free to send them. Thank you very much. Back to you, Kelly.
Great, thanks, Ben. At this time, I'd also like to invite David Sharp, MHCC's Director for the Center for Health Information Technology and Innovative Care Delivery, to make some opening remarks.
Good afternoon, Kelly, and welcome everyone. The only thing I would note is that it's very sort of positive sign to see so many stakeholders that have been keenly involved in our work that Ben noted from prior efforts to be part of this initiative, and we're excited to get the work underway. So I won't stand in the way of that happening today. Welcome, and Kelly, please proceed.
Great, thanks. Before we get started, I just have some brief housekeeping items to cover. During the meeting, it's appreciated if you could just keep your line muted if you're not speaking to avoid unintentional background noise. If you'd like to speak, just unmute yourself or raise your hand to ensure everyone who would like to contribute gets a chance to talk. If you have any issues with Zoom, you can contact my colleague, Justine Springer, for assistance. Her contact information was included in the email I sent this morning, and it's also in the chat. Also, if you're able, please add your organization name to your Zoom profile. You can do this by going to your profile in the upper right-hand corner of your screen and hovering over your mouse over your name. Then you click on the three dots and you can click rename. Next slide. So it's been just mentioned, MHCC convened a telehealth policy work group in the fall of 2020 to discuss changes in telehealth policies implemented in response to the COVID-19 public health emergency. So that work group suggested MHCC study quality and cost of telehealth and its impact on access to care, alignment with new care models, and consumer and provider satisfaction. Legislation, the Preserve Telehealth Access Act of 2021, was later passed by the Maryland General Assembly to maintain telehealth waivers through June of this year. The law included a study component for MHCC on the impact of telehealth as it relates to use of audio only and audiovisual technologies in somatic and behavioral health care interventions. The study yielded 15 recommendations as it relates to telehealth coverage, technology, payment levels and future study, terms in statute, and network adequacy, which was included in that final report for the Senate Finance Committee and the House Health and Government Operations Committee. Next slide. So this slide just provides a snapshot of activities completed by the National Opinion Research Center at the University of Chicago, who was competitively selected to complete the prior telehealth study and develop a technical report that informed development of MHCC's recommendations. Stakeholder engagement was a key component and included many of you on the call today, so we very much appreciate your continued participation. Next slide. So these next two slides are going to touch on the Interstate Telehealth Study and the role of this work group. The study is being conducted at the request of the HGO committee, and the scope aligns with House Bill 670, which was withdrawn by bill sponsors during the 2022 session. The work group is tasked with discussing barriers to interstate telehealth and identifying approaches that improve Marylanders' access to telehealth services from out-of-state practitioners, while also ensuring protections for patients and an adequate supply of Maryland practitioners. A recommendations report is due to the HGO committee by the end of this year. Next slide. So this slide highlights the matters included in the HGO committee's request for the Interstate Telehealth Study, and it includes insurance implications, medical liability, compacts, licensure, and impact on Maryland consumers and providers. So at this time, I'd like to turn things over to Dr. Eric Pan, Senior Study Director at WestStat and the project lead for the Interstate Telehealth Study.
Thank you, Kelly. On behalf of WestStat, I'd like to welcome you and thank you for joining today's call. For those of you who may not be familiar with WestStat, we are a 2,000 employee owned company based in Rockville, Maryland. So this is an issue important to our team members and their families. And we're very honored to be here working with you today to find the best interstate health telehealth policy for this people in Maryland. As Kelly mentioned, my name is Eric Pan. I'm trained as an internist and a certified clinical information specialist. And I have been specialized in health IT evaluation and also interoperability. I'm the project director for this project. I'm joined by my colleague, Shannon Reefer. We'll hear from later during this call. She brings us a decade of project management evaluation experience and also clinical experience as a staff nurse at both New York Presbyterian and University of Pennsylvania. We're pleased with this project to be joined by our colleague from the Center of Connected Health Policy, which is a program of the California-based Public Health Institute. And we're joined today by their director, Dr. Mei Kwong, who has 2 decades of health policy experience with federal and state health policies and over a decade of telehealth policy experience. And she'll help us navigate the issues to be discussed today. Mei?
Thank you, Dr. Pan, and thank you to the Maryland Healthcare Commission for convening this group today, and thank all of you for attending. Just a couple of quick things. As was mentioned earlier, please do not feel shy about speaking up or raising your hand. We'll keep an eye on that, but also we'll keep an eye on the chat too if you want to put in any type of comment there. I am not familiar with the majority of you, so it would be really helpful for me when you speak to introduce yourself and say what your organization is, just so I have an idea of, you know, where you're coming from and who you're associated with. Now, for today, we are going to have a fairly general discussion, and the discussion for today is really going to inform our future meetings. So we are going to focus in on the 4 questions that were shown earlier that were the focus of the report that will eventually be generated from this work here. So if we go to the next question, the first question, the next slide. The first one is how to address the health insurance coverage and medical liability issues associated with the use of out-of-state practitioners through telehealth. Now, I know from my work with the Center for Connected Health Policy, so if I didn't mention earlier, we're the federally designated National Telehealth Policy Resource Center. So though I'm based in California, I do cover and track all of the state telehealth policies, both for Medicaid, their laws and regulations as they relate to telehealth. So I do have some familiarity with Maryland, and I also know that you've done a lot of work in recent years around your telehealth policy. The point of this discussion is not to rehash any of that. The point of this discussion is really to look at your current policies right now regarding health insurance coverage and medical liability issues, and how does that interact with interstate telehealth, or, you know, services that patients in Maryland citizens will be receiving from practitioners who located outside of the state. So, for example, one issue that may come up with health insurance coverage is if a health insurance policy had something like you need as a provider providing services to an enrollee, a Maryland address. That may be something that impacts an interstate telehealth provider as far as providing services. So are there those types of issues or those types of points or policies that may impact an interstate telehealth provider from providing services to a patient here located in Maryland? Okay, Lori Doyle.
Hi, Lori Doyle with the Community Behavioral Health Association of Maryland. We have 110 members who provide community-based mental health and substance use disorder treatment. Just a question before we start. And is this all about how people outside would get, you know, services? People in Maryland get services from out of state practitioners, or is it the other way around as well? Is it both directions or just one direction?
I believe we're just focusing on one direction, in that Maryland residents receiving services from providers who are out of state. Unless Nikki, correct me if I'm wrong on that.
So I think that'll be a blend. I mean, I could welcome Ben or David to comment here too. I think we'll touch on both, but our task in the on the HGO letter was to expand telehealth services, interstate telehealth services to Marylanders.
Yeah, I think that's right. It is the charge at hand. So Nikki, that's correct.
Thank you.
Is there anyone else with any thoughts on this particular question? So I can tell you, like, this is actually an issue that other states have looked at and struggled with a little bit, and as far as how to address it. For example, some Medicaid programs have looked at their Medicaid policies to see if there's like an issue that is not necessarily related to telehealth, so it may not have been addressed, but does impact interstate telehealth. For example, a couple of years ago with California Medicaid, they did not have a policy set up for dealing with providers who are located out of state providing services within the state. And the policy that they were relying on to address that when telehealth was introduced was if somebody was traveling out of state. So that's what I mean by, is there perhaps like a issue, a policy that may not have been addressed because it wasn't connected directly with telehealth. And I see a couple hands raised. So we'll go with Diana Sue. And I apologize if I pronounce anybody's name wrong. So my apologies on that ahead of time. And then with Kathleen, we'll go after Diana.
Thank you, May. Yes, it's Diana Shu, very close. And so I guess my question is, if this is looking at getting Marylanders access to out-of-state practitioners, the first liability question that comes to mind for me is how do we, how can we track who those Marylanders are seeing? I believe that either last year or a year before that, there was a telehealth bill to basically expand out-of-state practitioners and to allow them to provide services to Marylanders. And we were concerned about any potential like disciplinary and, how to basically have accountability for those providers as they're giving services to Marylanders.
Mm-hmm. Okay, Kathleen.
Good afternoon, Kathleen Loughran with WellPoint. WellPoint, formerly known as AmeriGroup, is the second largest managed care organization serving Medicaid members in the state of Maryland. So thank you for the time and for the discussion. I had thoughts around Medicaid, obviously, and you touched on it a little bit, that individuals living in Maryland often receive their Medicaid coverage based on services being received in Maryland. However, there are some exceptions given the borders, including the District of Columbia and in some instances Delaware, for members who can see those providers, but they have to be approved to participate in the Maryland Medicaid program. And I think that that would also apply with telehealth. But that would certainly be worth exploring a little further. I'm not sure what, if any, prohibitions the Maryland Medicaid program has on telehealth that would be any different than a visit, an in-person visit or physical visit. I'm not sure what the distinctions are today in our Maryland Medicaid law or regulations around interstate telehealth.
Thank you, Kathleen. And actually, Kathleen, you touched upon something that can be connected back to what Diana brought up, and that was that with Medicaid program, in order for a provider to be reimbursed, they would need to be enrolled with the Medicaid program. So Diana, in response to yours, how would you track it, or how would you hold somebody accountable who is interstate? There's probably some mechanisms, at least within the Medicaid program, that probably does deal with that. But one other thing, Diana, also to get to your point about holding somebody accountable if they're interstate as opposed to within the borders of Maryland, what some other states have done, for example, there are a couple of states that have registration process now where you can get a telemedicine license or register as a telemedicine provider. And one of the points or one of the policies that to get on this registry that they have to agree to is to submit themselves to the jurisdiction of that state for any type of legal proceeding there too. So that's one way, but your point is taken that if they're outside of a Medicaid program, how would you track it? For example, if they were just a Maryland resident who just reached out directly to a telehealth provider, that would be a question that would brought up.
So if I could expand on that point just a little bit.
Mm-hmm.
Obviously, I have a stronger focus in Medicaid, but I think this is similar in the commercial market as well. I just don't play in that space very often anymore. But Maryland has CRISP, which is our data collection. And when, certainly in Medicaid, there are claims submitted for services to Maryland Medicaid members, those claims do find their way to CRISP. And I think the same is true for the commercial payers. So if you have payers in Maryland paying claims for services rendered to a Maryland resident, a lot of those claims, if not all, would be captured in our CRISP, and that would be a way to track.
Thank you for that, Kathleen. Is there anyone else Comments or thoughts on this? And I'm just going to check really quickly, make sure nobody has their hands raised.
So Mia, I was wondering if we could invite a couple people. We here know some of these folks very well, and might be good to get their thoughts. And I would invite someone from Hopkins who may be online with us. I think we have a couple folks here that can speak, or from the University of Maryland Medical Systems, Dr. Kraka. Perhaps you can provide some input here.
Yeah, and David, I'm happy to chime in while if Todd's on, and I see you've got Ethan and MedStar and all of our respective clinical leadership, and I'm sure there's more here from our respective systems. From my standpoint, this is kind of has one of the largest and most common questions tied with one that is atypical and seems perhaps not related to scope in some ways, which is health insurance coverage versus medical liability. And so I do think that they are in many ways distinct and separate. We all know that operationally, they may be connected in the workflow, but they're pretty discrete pieces. I would say that from a coverage standpoint, especially when we're talking about ambulatory services, and we can get into the acuity of services differently, but when we're talking about ambulatory services, which for any service goes through a registration process for any system, any practice, I'm not so sure I see the specific question on health insurance coverage for out of state as importantly tied to the rest of the discussion. So maybe we can think about that a little separately, meaning it's every practice's job to determine and inform the patient, if we take that insurance for that service, to give a fair representation around no surprises and do all the things that we regularly are supposed to do. The medical liability one really has two pieces. A system question from, does a system have a different med mal question in front of us and relative to our system policies? And then an individual one that relates specifically to how the state boards might think about out-of-state providers. How might that particular out-of-state provider be disciplined, governed, or otherwise, reviewed, if not subject to our various state boards and professions, of which obviously there are many. That's not just a physician discussion. And I do think that will continue to be a question that will need to be debated as this working group evolves. What are the interests of our state and our constituents for balancing discipline and governance versus, real benefit of opening up additional access to different constituents, many of which who do not live near centralized urban areas with high density of certain kinds of clinical care. I don't know if Ethan or Todd or others want to kind of weigh in on the two aspects of this discussion.
Yeah, I think Dr. Krako or Dr. Booker, and then I think I had a quick follow-up, if Mia doesn't mind, to your comment.
Ethan, go ahead. Yeah.
Go ahead. Thanks, Todd. And thanks, Brian, for teeing it up that way, because I actually did have the same question, really, of teasing out these two things as really quite separate. And I also wanted to separate out the question of medical liability from a medical malpractice perspective from one of provider licensing, which is the enforcement aspect of what you're describing, all of which are, both the medical malpractice and the provider licensing issue are complaint-based processes whereby a patient would be generating the information and or complaint against a provider providing care both for medical malpractice and for licensure capabilities, and would refer to documentation of that proceeding, which is how you would identify who the provider is and where they're licensed. And I think I would probably put the question back to the group at large to understand those states that do have out-of-state telehealth provider registrations, which I think is a reasonable way to go about this. what's the experience of those places, which by and large, their registration requirements are registration with a local agent, which is the way Florida's is worded, and maintaining liability coverage at or above the standard for that state, which I think again is a reasonable way to pursue it. And then, you know, I am my practice as a clinician is primarily in the District of Columbia, but I maintain a license in Maryland. But certainly many folks from Maryland come to the District of Columbia, as Kathleen mentioned, you know, mostly commercially insured, coming, you know, is different than obviously Medicaid coverage, coming to get services at Georgetown or at Washington Hospital Center in our system, or Sibley in the Hopkins system. And if they have an issue, their liability complaint will come to the District of Columbia, not to Maryland, despite the fact that they are residents of the state of Maryland. They received services in the District of Columbia, and that's where they would pursue a complaint. And I think there's a similarity here for telehealth about a home institution for the provider being the person who's responsible for having that liability complaint or provider complaint. The question of health insurance coverage is frankly so complicated that I'm not sure I could speak well to it regarding registration, network adequacy, which is an important part of this entire component. And I do think they should be handled separately, although I understand why they're in the same question.
Yeah, I think that's a good point. And I did want to ask a question about that network adequacy piece. So David Cooney is with us from the Maryland Insurance Administration. Perhaps in a moment we could get him to speak a bit on that. But Dr. Krakow, your thoughts.
Thanks. I'm not so sure there's much for me to add after Brian and Ethan spoke, but I too gravitated to the medical liability issue. I think, Ethan, your comment about looking at states that have a telehealth registry, I guess, you know, the one thing that I'm focused on is, so how do we go about this without reinventing the wheel? There have got to be other entities that, or systems, areas, regions, whatever the correct term is, that have already been in this and have lessons learned. So rather than us trying to figure this out de novo, looking at other systems and going from there. But otherwise, I think Brian and Ethan covered it well.
Yeah, and Dr. Krakow and Dr. Booker and Dr. Hasselfield, thank you very much. And I did want to note that while we're looking at interstate telehealth in Maryland, there's elements of the services that you all as health systems export, because you all do telehealth, certainly broader than in Maryland. And I think, Dr. Krakow, to your point, maybe there's lessons learned or some of the experiences that you have in terms of actually exporting these services that you're doing that can be considered into this, into the recommendations that we're developing here, because I like the way you said that there's other models out there and people have been doing it. So there's got to be lessons learned. And this is an area I think our executive director has been involved with a bit, and he may have some thoughts about exporting of services, and that we don't want to overlook that as an element of the recommendations or the report. And perhaps I should yield to him at this moment, see if he has any thoughts.
David, I think you did a good job not wanting to completely dominate this discussion. I think you captured it that although we cannot affect what other states are doing, the Maryland can be creative and think about how our approach might serve as a model. But I am aware that it's a two-way flow of services, and although we can't tackle directly what other states are doing, it's important to keep that in mind. Thanks. Go ahead.
And I just asked the facilitator to indulge me another moment while we ask for David Cooney, who's from the Maryland Insurance Administration, to talk a little bit about the, we heard Dr. Hasselfield and others bring up the network adequacy component and the insurance coverage piece. Can you clarify or add some dimension to the things that you all are seeing, or some concerns that the agency may have had or has related to interstate telehealth?
Sure. Thanks, David. Again, this is David Cooney from the Maryland Insurance Administration. So we have been in the process of revising our network adequacy regulations for a couple of years now, and telehealth is something we've been looking at very closely. Hopefully, a formally proposed version will be actually released in the Maryland Register anytime now. We're just waiting for it to show up in the Register, essentially. But what we're looking at there, we looked a lot at telehealth. In our view, from all the research we've done, what we've seen, telehealth is a fundamental part of a network being adequate. Without telehealth, the network is not adequate. But at the same time, insurance companies can't rely solely on telehealth, and there has to be that access to physical services for those who want or need the in-person services. So we really look at it as a complement to the in-person services. And as the draft regulations are set up, insurance companies would get a level of credit for having telehealth in their networks. But again, it can't be at the expense of in-person coverage. And I don't really feel that this is just an issue broadly for telehealth in general. The interstate aspect of it doesn't come into play so much, other than, again, if there was an insurance company, for example, that had a telehealth vendor that was solely out of state, and there'd be no ability for consumers to see those same providers in person if they were trying to get some kind of hybrid approach. So, that would not be a sufficient way to address network adequacy if it was solely through out-of-state telehealth. But as we're looking at the regulations, that's not something that would be permissible. So again, for network adequacy specifically, as we're approaching it, the interstate aspect of it isn't as significant in general. It's just the underlying issue of telehealth in itself.
Okay, thank you, David.
Thank you, gentlemen. I want to make sure we get to Robin. She's been patiently waiting. So Robin.
I think you're muted, Rob.
Great. Thank you. I'm doing that thing where I'm audioing in by phone, so it's a little more complicated. I just wanted to flag, this could be something that the group could talk more about. In the 2020 legislation that passed related to health occupation boards, there is a provision that directs the governor to work with adjacent states to encourage the adoption of interstate compacts. Maryland is a big compact state. We adopt a lot. And so this clearly benefits in-person care as well as telehealth care. But if we're thinking of Marylanders who go to other states for their jobs or to visit nearby family, having more interstate compacts would really be helpful. I also wanted to recognize some of our boards are doing very, very creative work with endorsement and other reciprocity arrangements. So even though we can't technically make another state adopt a compact or enter into a reciprocity agreement, I think there is quite a bit as a governor in working with adjacent states and the leadership in those states that we can accomplish and encourage those types of arrangements. So thank you. And I would love to have that as some kind of future topic. I know, for example, I myself am working on a licensure compact bill in DC, and it has been stuck in the process. So I know that this is a real challenge, and I think the governor and the executive branch could be helpful.
Thank you, Robin. And we are going to talk a little bit more about compacts in a separate question a little bit later in the meeting. So we will definitely dig a little bit deeper into that, but acknowledge, that is also like another route beyond like these telemedicine registries that we're talking about too for interstate telehealth providers as well. And also I want to acknowledge that Dr. Booker put into the chat the Florida provider out-of-state provider registration and a link there if anybody would like to look at that. So as I'm hearing this discussion that's gone forward so far, we have two very distinct, but maybe even three very distinct issues that we've been talking about here. There's the health insurance coverage issues. There's medical liability, which splits off into sort of two separate discussions of their own, the coverage of that, but also the enforcement of when something goes wrong as well too. So we're teasing out these issues a little bit more. We have also talked about maybe looking at, as we say, not reinventing the wheel, but what other folks have done as well too in other states. I will say a lot of these registries are fairly new, so I don't know if there's like enough information that those states would be able to provide as far as how well they've been going to provide that feedback to us, but that is something definitely that can be looked into a little bit further and engaging with them. I think they've been around at least a year, so they may have some data or information that they're willing to share with Maryland. But as was also pointed out, you know, telehealth did not start with just COVID. So there have been providers who have been providing services interstate for a while there. Are there some lessons or information that we can gather from like their experience of like years of doing that could be informed here as well too? And yes, go ahead.
I'm
David.
sorry, I was just going to ask, because you mentioned the health insurance coverage piece. I was wondering, we have a number of payers. We have Kimberly Robinson on, who represents a payer, and we have Kathleen Logren, who talked a little bit. But I was wondering if the commercial payers, if Kimberly might have something to share to us as it relates to the health insurance coverage component for that carriers run into for interstate telehealth.
Hi, David. This is Kimberly Robinson for Cigna. I'm a little under the weather, so pardon the voice.
No worries. Thank you for joining.
My insight on some of this is currently a little limited. I actually have some internal meetings to learn more scheduled. But speaking only for Cigna, we are supportive of states finding workable pathways to allow interstate telehealth. We do support the idea of expanding access for patients. And in particular, in certain specialties or in certain communities where there's just an actual shortage of on-the-ground providers, not a matter of providers not being in network, but just an absence of providers, anything that helps ensure that patients are getting appropriate access, appropriate for telehealth, of course, not a substitute for in-person when that's appropriate, but when appropriate, we think is important in ensuring that people have access to care. We are supportive of interstate compacts, which Robin mentioned. And because we are a national health carrier, our network is in fact nationwide. And so often we will have the ability to have a provider who is in another state, but still in network as, you know, potentially the provider who's providing that service. So it doesn't necessarily pull someone out of network simply because they're seeing a telehealth provider. Many carriers have relationships with specific telehealth vendors for the same reason, to create a system of a network that's going to ensure that patients are getting the best financial advantage as they're seeking services through this modality.
Thank you. And could I also invite Susan Drake from Care First to share her perspective on the health insurance component? Susan, you may have yourself muted or...
Oh, yeah, I had myself on mute and unfortunately couldn't find the unmute button because of the way my screen was displaying. I actually don't really have much to talk about right now. I'm actually just sitting in for Deb. And so I'm going to refrain from making any policy statements. And I'm also here more as a subject matter expert of understanding the unique ways that Blues function.
Okay. Any other payers want to weigh in on the health insurance component? Okay.
Okay, we've got a couple of hands raised, but before we move off to payers, I actually just had a general question for you because we've been discussing medical liability for so much. Do payers have some type of requirement about medical liability coverage for their providers that they're supposed to have? Just in general, it doesn't have, I'm not asking specifically telehealth, but just even in general.
So this is Kimberly again. In order to participate, and I'll just say this is a general statement, I can guarantee that to participate in any carrier's network, we do credential providers, and part of that credentialing check requires them being able to demonstrate they have appropriate professional malpractice insurance to cover for any medical liability. We look at their practice history, we look at disciplinary actions against them by any given state and evaluate, you know, how severe they are or not. So we are not just, so we do evaluate providers in a certain way before they become part of the network, and liability is a part of that, ensuring that they've got coverage for it.
Yeah, and this is Kathleen Lochran again from WellPoint, and the same is true for Medicaid. There's also an additional requirement in Medicaid that they have to be approved, not just locally, but nationally, to serve in the Medicaid program. So in other words, they cannot have an action or a prohibition against them that would prohibit them from being a Medicaid provider. And that would be true even for these telehealth providers that we may contract with. They have to be permitted to serve in the Medicaid space, in addition to the usual credentialing and liability requirements for practicing.
Thank you both for that. We've got a couple of hands raised, so we're going to go to Ellen Weber first, then Katie Norrell, and then Dr. Hasselfeld. So Ellen?
Thanks very much. It's Ellen Weber from Legal Action Center. I guess some of the comments have just raised the questions around sort of transparency for consumers. I think it's important in all situations to sort of keep in mind the kinds of sort of plain language information that needs to be provided to consumers so that they're fully aware of sort of platforms that need to be used, of provider networks that are going to be available, implications for in-person services, and various cost sharing and other factors. So those are items that I think need to be, attention needs to be paid to that. We do most of our work in the substance use disorder and mental health context, and in those contexts also want to ensure that other federal laws are adhered to that prohibit discrimination against coverage for mental health and substance use care.
Thank you, Ellen. Katie?
Hi there. My name is Katie Nerrell. Some of you may know me. I'm one of the newer members of MHCC, and I did come from 20 years working with Medicaid. And so, Kathleen, I will just piggyback on what you were saying about Medicaid's rules, and also make a comment that if you are a provider of Medicaid services, you must be licensed in the state that the participant is receiving services in. So I can see that as being something that will want to be looked at in the future. And if we're going to create a registry or some sort of a compact, which I know very little about, we would want to make sure that the providers have some way to be licensed or to get around that licensure, which may not be the most the most appropriate thing to do in order to get those recipients served. Additionally, in Maryland, part of the credentialing, they do at this point in time need an SDAT through the State Department of Assessment and Taxation in Maryland. So that would be another requirement that would have to be worked around in Medicaid.
Thank you, Katie. Dr. Hasselfeld?
Thanks. And there's actually a great additional kind of piece of information from Katie, because it highlights where I think the group, in my opinion, could try to help focus a little bit. Whenever, and many in this state know that we've been very active over the last few years on this topic, you know, in Annapolis and across the state. So we're very deep in these topics for our own state. That the very first question I always ask our team is, how is this different than in-person care? And all the aspect from an operational standpoint, and every aspect that has been raised outside of the fact that the providers outside of the state is really, really similar or the same for in-person care. So credentialing with Cigna is required for providers to care for their members. Credentialing, care standard insurance requirements. Credentialing with Maryland Medicaid, standard for all providers that may see Maryland beneficiaries, inclusive of the requirement to be licensed in the state where the member beneficiary is located. So none of those operational pieces are different for telemedicine than they are for in-person care. And I think we really need to hone in on what is different. And what is different is that those providers are may be located anywhere, and two, may not beforehand have a license and still want to care for people in our state. And it really does come down to physical location of the provider and license in the state of Maryland. Those drive all of the other differences. The insurance requirements, credentialing, registration with Maryland Medicaid, those have to happen. Those happen for all providers that care for those members. So I really do think we need to narrow and focus on what we all know is the crux of the issue. We cannot legally see patients in another state where we aren't licensed, and that drives all of the downstream issues. And that includes discipline around liability, does not include health insurance coverage in any way, shape, or form. I have to follow the payer's requirements to be able to be reimbursed.
So, Dr. Hasselfield, we are fortunate to have Denise Shope and Derek Yarmus that represent some of the liability carriers. And I wonder if there are sort of different issues in different states related to liability insurance or awareness of that. Because what we wouldn't want is a physician to find themselves entangled in the wrong situation, because even that there was variation there. So Denise and Derek, can you talk a little bit about what you see and what your experiences are?
Sure. I think to Brian's point, the insurance is going to follow the provider. So it's up to the individual provider or his employer to assure that he has the appropriate medical malpractice insurance. So depending on what state he or she is in, and again, they're licensed in that state, they're going to have to assure through their broker, through their insurance company, that they have the appropriate limits within that state. Then if that provider is providing interstate telehealth within another state like Maryland, then the limits of liability would have to apply as well. So there's a whole credentialing process that provider would go through in order to provide those services. But the insurance follows the provider. So if the provider resides in Delaware, for example, or Pennsylvania, then that provider would have to have insurance within that state and be licensed within that state. And then one of the underwriting questions that the insurance company would have is, are you providing interstate telehealth? And if you are, where? And are you licensed in those states? And then again, insurance coverage would be extended to that program, again, depending on where that provider is providing the telehealth services. I hope that helps answer some of your question.
So, Derek, is there anything else to add here?
Yeah, just it's Derek Yarmus from Medical Mutual Liability Insurance Society of Maryland. Just to add to what Denise said, one other consideration is different insurance companies are going to have different underwriting guidelines and be more permissive or more restrictive in terms of their insureds practicing telemedicine across state lines. And that also it could impact a rating as well. If a provider in state X is practicing a large amount of his or her practice in state Y, and state Y is an uncapped jurisdiction, does not have a cap on medical liability judgments, and the tort environment is otherwise less favorable, that provider is going to be paying more in all likelihood, going to be paying more for med mal insurance if the carrier even is permissive of the interstate telemedicine practice.
Yeah, I agree with Derek. I think where there is risk, and the risk being, again, from the consumer or the patient, is where that consumer or patient who is a resident of Maryland, the population that we're most concerned about, is accessing telehealth services, e-health services through the internet, and not really knowing who they're, depending on the type of service. So whether they're trying to get a prescription for something or a consult, not really knowing who the provider is on the other end and the credentials of that provider. So sort of being sort of a little bit rogue. And again, from a patient safety perspective, do they really know who they're talking to or who they're interacting with? That may very well be a very separate issue from this question, but if we're concerned about the population in Maryland and the quality of care and the potential liability and risk issues that that patient may incur, that's another area. There's a lot of again, kind of one-off health, and I'll use the word healthcare services provided via the internet, via telehealth, that patients, consumers have access to. They have no idea the credentials of the practitioner on the other end of the phone call or the Zoom call.
Thank you, Denise. I'm going to take one more question. Dr. Hasselfeld has his hand raised, but after this, I am going to move us on because we have 3 more questions to address, which I think actually relates to some of the things that have been brought up in this discussion. So Dr. Hasselfeld?
Yeah, thanks. Then we can move forward. I want to make sure that we continue to work with the kind of the data on the ground versus kind of the theory. And we certainly all know from from the broader Medicare claims analysis that most telehealth is consumed by established providers that people know, and most cross-state telehealth is with established providers within 15 miles of the border. So, I just want to ensure that we're all working with the same set of data validated on multiple Medicare claims analyses, that we do continually and always need to be focused on the risks of fraud, abuse, safety, and quality available through various pathways for healthcare. Today, the pathway for protecting our constituents and citizens is through the boards of professions and licensure. And I think we just should continue to focus on whether or not that is our long-term pathway for governance around safety, quality, fraud, and abuse, or if the interests of our citizens here in the state in accessing care kind of alter that question. So I don't think that this is specifically should be anchored around the fringe margin that really isn't supported in the data around telehealth utilization at this point.
Thank you for that. And thank you for this really great discussion. As I said, we've been taking very copious notes here, and this will inform future meetings as well. But I am going to move us on to the next question. If we go to the next slide, because we do have 3 more questions that we would like your input and feedback on. And as I said, the previous discussion kind of leaked over to some of these other questions. So feel free to continue some thoughts that you may have brought up in the last discussion. And this is around health compacts, interstate health licensure compacts, and are they sufficient for expanding the use of interstate telehealth? I believe it was Ellen who brought up that Maryland is a member of actually quite a few compacts, and there are quite a few compacts out there for different professions as well. The question is this all that's needed out there? And Dr. Booker, I see you have your hand raised, so I'll turn it over to you.
Yeah. Shortly, no. The existing physician compact is inadequate, has been in place for many years, and is not adequate for the needs of many providers who need to carry multiple state licenses. The existing compacts, which many people point to as a mechanism to provide interstate licensure, are essentially a repository for documents, but don't overcome the wait times, the cost, or some of the issues that we've talked about here for liability or insurance, nor do they address the issue that many states now require very specific ongoing medical education or continuing medical education credits that are specific to certain types of information and data. And so while there is movement of documents through the IMLC compact, it does not improve the mechanisms for maintaining multiple licenses across a region like I do. It essentially adds cost, doesn't subtract time, doesn't make it any easier for physicians to maintain licensure. There are certainly other professions that have an easier and more streamlined mechanism for compacts, as Robin pointed out in her earlier comments. But for physicians, it's not helpful the way that it's currently constrained. And I would strongly advocate for something that looks more like reciprocity or registration that takes advantage of my existing state licensure to be able to register me in other states.
And I apologize. I said earlier it was Ellen. It was actually Robin who brought up those comments about compacts. So Robin, you have your hand raised.
Thanks, Robin, you could be muted.
I think I'm on now. So yes, I just thank you for that last comment. Did want to acknowledge that the physicians compact is much, much different than the compacts for other health professions. Generally, the nursing compact looks very similar to compacts we have with occupational therapists, physical therapists. There's one coming for social workers, psychologists. All of the other compacts operate in probably a much more expeditious fashion than the physician's compact, which is essentially if you are a member, if Maryland is a member of a compact, someone can apply for essentially an authorization to practice in another compact state, and it's a very easy process in general, and so just thanking the prior speaker and acknowledging that there are differences in how compacts are constructed. But I think most of the compacts that we see coming online now are much more efficient.
Lynn?
Thank you. I'm Lynn Lindy, and I'm the Chief of Professional Practice at the American Counseling Association and the project lead for the Counseling Compact. So I want to support what Robin was saying, because there are so many occupational licensure compacts coming on board. Maryland passed the Counseling Compact in 2021, and the commission is up and running, and they will be granting privileges within the next probably 9 months. It addresses a number of the concerns that have been raised, because it actually enhances the ability to track violations across state lines. It shuts down some of the practicing without a license in other states. There are currently 17 states that have signed on to the Counseling Compact, and we currently have legislation in additional 17 states. So it looks very likely, as Robin said, DC is a bit of a mystery. Virginia is likely to pass it by the end of the month. Delaware is a member. Pennsylvania has legislation in. West Virginia. So all of the areas around Maryland are participating in the compact. It does address the use of telehealth. That is part of the compact. It has a mechanism for tracking who is practicing. So that was one of the concerns. One of the other concerns I heard raised is the issue of qualifications. And one of the things that I've learned from working with licensing boards is that everyone thinks they've done it better than everyone else in the country. And they probably have, but there are regional things that are specific to states, and compacts are based on trust. You have to trust that everyone else is doing their due diligence and no one is being granted a license who isn't highly qualified. And that is a leap of faith, but everybody is getting there because the benefits of compacts, I think, outweigh it. The need to have specific requirements. We're talking about people who've been practicing for a lot of years, at least in the Counseling Compact. And so we're not talking about people just out of graduate school. So some of the state-specific requirements are less important because people have years of experience that have enabled them to be able to work effectively. So the answer, though, is that they're not sufficient by themselves because not every state will sign on. The advantage they have over reciprocity agreements or registration is that it is a legislative solution and therefore it's permanent, whereas reciprocity agreements can come and go. And it depends on the prevailing politics of the situation, whether they continue. So I think that compacts have some advantages, but unless all 50 states and all the territories sign on, then there's always going to be an issue.
Yeah. Thank you for that, Lynn. I think you hit upon at least one of the major issues with compacts, in that you have to be a member of that compact for it to like really work. So we touched upon the physician licensure compact in particular, and I saw a couple of folks from the Federation of State Medical Boards are also on here. I know you did the model language for that particular compact. I don't know if anyone from FSMB would like to comment on what was said earlier.
Well, this is Lisa Robin from the Federation of State Medical Boards. Yes, well, the Interstate Medical Licensure Compact, is developed by groups that from supported by the Council of State Governments and medical boards. It is, as you mentioned earlier, of all of the health compacts, it is the only expedited licensure model that exists. There are, I think, with every compact that's developed, they've learned some things, but I think all the points made today are certainly reasonable. And there are many states really now that have not only the compact, but also at the same time using other models, whether it be registration or certain exceptions, exceptions in telemedicine policy. So I'm happy to provide any data to this work group as we move forward, if that would be helpful.
Yeah. And thank you. And Mia, could I invite Dr. Ritter, who is also on the call today? She may have some experience to supplement what we've heard from some of the other physicians. Dr. Ritter, are you able to speak? Welcome.
Sure. Thank you. Yes, I'm OBGYN, and I'm still practicing full time, and I'm a member of MedChi and have been on the Board of Physicians for 3 years now. So all of this is playing out on the ground. If you want ground level information on this from OBGYN point of view, it's very, very prescient now with what's happening in women's health with telehealth and mifepristone and women in other states who have to find an address outside of their state in order for me to practice. I have a license to practice in Wisconsin, so I'm actually doing this through the compact. And from the licensing board, I'm realizing it's very, very difficult to monitor these doctors. We have no enforcement control at all. Our hands are really put behind our back. I've actually been dealing a lot with a lot of apps. Patients go online and they Google, how they can treat their UTI or whatever their symptom, and they'll get an app and they'll get treatment with a doctor that they have no idea who it is. And then they come to me and they say, oh, I had a doctor who treated me. And like, who is the doctor? Well, I don't know, it was, somebody in this Lemonade app, and so I don't know what they were treated. They have no relationship with a doctor other than they talk to them. And a lot of times it's not even video. And then the doctor from the app will send them a prescription. And then I have no record of it. So so from multiple points of view, this is really important work, because it's like the wild, wild west out there right now when I'm working on the ground. And from the physicians board, we all we can do is do the best with what we have been given through the statutes and the regulations. So I'm learning a lot, and I plan to, listen more than I speak here, but whenever I have anything to inject, I will try. Thank you.
Thank you.
Thank you. Lynn, I was going to ask if you had something else. You put your hand down. So there is a comment from Dr. Booker. The IMLC, the physician compact, was passed in DC in 2017, has not been enacted such the board can actually process the application. So while in place by law, it does not practically work. It is not active in Florida and California, and legislation was passed in Virginia this year to adopt. So thank you for that, Dr. Booker. Again, that is one of, I don't want to say a flaw, but one of the things with the compacts is that you do need another state to join if you are perhaps interested in having certain providers from other states also provide services. So that is one of the drawbacks. We'll just say that for a
So
compact.
Could I ask a follow-up to then to Dr. Booker's question? I think you're saying it was passed but not enacted. Is that
Correct?
But I don't understand why would that happen?
So the board of physicians still has to have the infrastructure to take their credentialing from SFMB and then process that through the established credentialing process rather than their own native credentialing process. And so it's essentially unfunded legislation in the District of Columbia. So while it's the law, it's not been enacted in a way that actually makes it practical for someone who's licensed, say, in Maryland, to use the compact to become licensed in the district. Most of my providers who have established a license in Maryland go directly for a brand new license in the district rather than using the compact.
So is this Dr. Ritter comment sort of along the lines of what you were saying?
Yeah, it's basically what I believe is when you go through the compact, like you said, it's a trust thing. We have to trust the other state. It happens very fast. And one of the critical things that we don't get on the compact that we do get when we license in the state is the criminal record check. There's no criminal record check on the compact, as far as I know. And that is definitely a trust issue.
Okay. Thank you. I'm sorry, Dr. Ritter. We've just suddenly had a bunch of hands pop up and I saw Lisa shake her head. So, or Lisa, do you want to go ahead first?
Oh, I was going to say on the criminal background check issue, the actual legislation in the IMLC requires the state that's issuing the letter of qualification to conduct a criminal background check. It is a requirement of every state. That information, a letter of qualification can't be issued until the criminal background check is completed, and that's in the legislation.
Okay, and I apologize, Dr. Ritter. I cut her off. Dr. Ritter, I just want to check to see if there was anything else that you wanted to follow up with before we move on to the people who have their other people.
No, that's good because I see David Finkler has his hand up and he can probably clarify things a lot better than I do.
Okay, I think Kathleen was first, and then we'll go to David.
Yes, thank you. So just quickly, I'm hearing particularly from the physicians about barriers, some at a high level, some are a little bit more specific, but it would be really nice to have a summary or a list of barriers that exist to these compacts so that even though a jurisdiction or a state may pass a compact, they're not attracting any of their border states, for example. What are those barriers? What is it that is preventing multiple states or regions from participating in a compact with each other?
Thank you. David?
Hi, I just introduced myself. My name is David Finkler. I'm with the Maryland Attorney General's Office, and I'm counsel to the Maryland Board of Physicians. And I'm very hesitant to speak on behalf of my client because they're much better in a better space to answer some of these questions than me. But I just wanted to address a couple of things that have come up before. First, Robin Elliott talked about compacts with adjoining states, and I don't think that people are aware, but there is reciprocity that the Board of Physicians has been working on with Virginia and Washington, D.C., both who are not members of the compact or, like Dr. Booker said, not maybe only in name only. So the board is working on, I know, on reciprocity with both of those states that would allow a very expedited license to be given in Maryland. The board is also working on licensure by endorsement, which takes that issue of faith that had been raised earlier, and it means that doctors who normally would have to submit all their credentialing from the hospitals that they worked at and the med school transcripts and all of that, that the board would run down and make sure that all of those elements are accurate because they're already licensed somewhere. So we have more faith that they've actually completed those requirements, and it would make licensure go a lot faster. My understanding is that's already live and and created in order to expedite licensure and make things easier. And I just wanted to encourage this group to include Board of Physicians staff. Dr. Ritter has a really helpful clinical perspective from all of this, but she's not working on, directly through the compact. As everyone's noting, you do need a criminal history background check for the compact, and I think that it would be helpful to have Board of Physicians staff to respond to some of these inquiries, especially related to the compact and related to the issue that we're going to get to later about licensure and what changes need to be made, because they do have the expertise and they have been working on these issues to make licensure easier for applicants, and while still maintaining what Dr. Shu was talking about, which is who's concerned about disciplinary actions and accountability. And the concern with removing a licensure requirement is that you remove the state's ability to to discipline doctors and to promote accountability. So there is some concern with that. If you keep licensure as is, which is the way that the state generally does this, then those things will still be in place. And right now, as long as you're licensed in Maryland, there's no limitation on telehealth from people who are out of state. I think a registration is a really interesting idea to allow the board to have a better sense of, among licensees, who's coming from out of state and who's not. But I just want to raise those issues and answer some of the questions that have come up.
So David, can you restate what you just said? Because I think some of us are hearing it two ways. Are you saying that, you mentioned about—
Oh, this is actually, it's more of a question than a statement. The registration, I've been hearing a lot about registration, and I'm curious whether that is a registration for out-of-state doctors in place of licensure, or if that's in addition to licensure. Because I think that that's a really interesting distinction. That's certainly a registration that helps assess who's out of state and who needs maybe additional, who's coming from out of state and who's not, is really helpful. I think a registration instead of licensure, where you create a parallel disciplinary process, raises questions about, again, like as a bunch of people raised, are we reinventing the wheel? And I do think that there might be some issues with reinventing the wheel in terms of creating a new licensure by creating registration and disciplinary process through that registration if it's outside of licensure. But if it's in addition to licensure, I think that that's a really intriguing option, certainly.
But to the physicians who spoke earlier, just to clarify, what I think I've heard you say is that to provide interstate telehealth, the physician has to be licensed in Maryland, at least at the moment.
Correct.
Okay, and then my last question around that, and perhaps some of the physicians could answer this, because David, you might not know. Operationally, what is the turnaround time for, in general, for an applicant who seeks to be added via the compact in Maryland?
I wish I could give you numbers. Again, this is why I really do think that involving the staff from the Board of Physicians would be helpful. My understanding that it's a pretty quick turnaround time, that usually the longest element of what takes the longest is the criminal history record check, which was imposed by legislation and is required by the state, and that it takes longer for you to get the fingerprints done and sent in and verified than the rest of the licensure process. I really think it's under 2 weeks. But please don't hold me to that, because I'm not a staff member. This is through discussions on this topic. So I think that that's and I think that that's our take on the compact too, is that it doesn't actually save very much time, but because the board is aware of that, it has been trying to take steps, especially for people who are out of state, to really expedite those licensures. And that's why this licensure by endorsement is going to be, I think, a really helpful tool for out-of-state doctors who will have a very slim licensure application. It really takes away all of the difficult and arduous parts of the application, and really puts it to the board to make to do those things, which again, because we're working with FSMB, we are able to get that information a lot faster. That once they have this information in the system where their transcripts, they don't need to submit it again. So again, I think that it's important to include the board because they are working on these issues, they're aware of these issues, and they're trying to help out. And I think having someone there who could actually answer these questions would be helpful.
Okay, thank you.
Thank you, David. And in answer to your question, the registration so far from the ones that I've seen, it's in place of licensure. So if it's not like registration and licensure in that state as well too. So that's the answer to your question on that one there. So thank you for your comments and your insights here. One thing I do want to point out about the compacts, and it's been alluded to in the discussions, that a lot of the focus has been on the medical licensure compact, the one for physicians, and there are like other compacts out there, and they're not all the same in their approach and how they do things as well too. So I just want to make sure that everybody understands that in their approach, it's not the same for all of them. I am going to move us on, and actually our next question I think is really related to this in a lot of ways. So it's going to be a bit of a continuation of our discussion here, I think, is whether Maryland should alter its licensure practitioner requirements to further the availability of telehealth services while continuing to protect patients, and if so, how? That's been sort of elements of like previous discussions here, but now we're really going to drill down a little bit deeper into this. There have been brought up through a lot of the previous discussion regarding patient safety and ensuring, how you can do disciplinary actions if something goes wrong. But what are your other thoughts regarding this? And we'll go to Kathleen first.
Thank you again. So my gut reaction on this is, one, we should really understand whether or not changing those requirements will be helpful in terms of entering into compacts or agreements with other states. I don't want to see Maryland sacrifice its provisions, which may or may not provide a higher level of protection than surrounding states, if it's not going to be useful or appropriate for the delivery of care through interstate telehealth.
Thank you, Kathleen. Anyone else regarding this? I know we've had like we touched upon this in previous discussion, but any further comments that folks want to make regarding this? I will say that a couple of what other states have done in relation to some of this, as far as, relaxing may not be the best word, but in like easing some of their licensure requirements. And I think it was brought up by, and I apologize, can't remember exactly who, it was alluded to, may have been Dr. Hassefeld in an earlier point of discussion. Some states have, as far as their licensure requirements, made exceptions for certain situations, such as if there was a patient-provider relationship that had been established previously at some point. For example, college students, that was a big thing. College students traveling to another state, but still receiving services that they had received from their practitioner who they saw at home. So there have been some exceptions made in other states regarding those types of relationships as well too. So just as a little bit of something for you to consider. Other thoughts regarding this?
So I wonder if we could look at it from a behavioral health perspective for a moment. Ellen, can you give us some insight from your thoughts, or Lori Doyle?
I was sitting here thinking of this question, Lori Doyle with CBH. And what I hear from my organizations all the time is the length of time it takes to get someone licensed here in Maryland, not necessarily telehealth or that kind of thing, but just somebody coming in who may have been licensed in another state, that there seem to be, delays in getting that, depending again on the time of year, getting that finished. And the same is true on the commercial side of things around credentialing, significant delays on getting practitioners credentialed. So I know we're talking about telehealth, but to the extent that we could have more practitioners here in Maryland, if things were a little bit faster, I guess, you know, realizing you have to go through your due diligence, but I think it's all one part of the picture.
I saw Diana's hand go up earlier, but she put it down. So Diana, I just want to check to see if you wanted to make a comment before we go to David, who has his hand up.
Sure. Thanks so much, May. Sorry, David. So I wanted to, my comment was about what you were mentioning earlier about working like for students who leave Maryland to go to school out of state. And you were talking about how they work with their existing providers or for the out-of-state providers to work with their existing providers to sort of have that type of collaborative care. And so to David, thank you for the promotion, but unfortunately I'm not a doctor. My training is actually, I'm an attorney by trade, but I'm a senior policy analyst with the Maryland Hospital Association. But it does remind me about like, you know, where it reminds me for some reason of like, you know, how there's something in the legal world with pro hoc vice, which is something where you have attorneys that are out of state work with a provider that's in state. And that's how you kind of get a pathway towards being able to represent someone in another state. So it was, I was just interested in hearing more, I guess, from you, May, about, you know, how those collaborative agreements seem to be working.
I'm going to let David go first before I answer that question. David, and then Dr. Booker, I see his hand raised as well too. So David.
So just a couple of responses regarding what Ms. Sue was saying. I think that we already have, if you are working with a doctor on a specific patient, you can already, there are exceptions to licensure for that sort of thing. So that already exists. What we're talking about here is really telehealth for new patients and for, you know, a range of patients and that sort of thing. I did get an answer. I texted one of my colleagues who works at the Board of Physicians, and he said that 95% of doctors get licensed and issued a license within 10 days or less. So it's actually quite rapid. But he did acknowledge that that is after they've submitted all of the documentation, and that with one of the difficulties and holdups is that we're not allowed to process the application until we have the criminal history record check. And for out-of-state physicians, that's especially an issue because they in state, you can just go to there are certain places where you can get fingerprinting done and then it gets sent electronically to the board. But if you're out of state, you need to fill out a fingerprint card and then mail it to the board, to the institution that looks at the fingerprints, and then they have to analyze it and make sure it looks okay. And if the fingerprints are smudged, then you might have to go back again. So I understand that it does take some extra time, but unfortunately, that's the way that the law is currently drafted, and it really has a lot more to do with requiring the criminal history record check than the board processes. So unless the registration didn't require criminal history record check, I think you'd probably be in the same boat in terms of the timing. And again, if the criminal history record check isn't required for the physicians, it would also presumably allow it to be along with those other 95% of the cases where it's within 10 days or less. So I just wanted to address those because I did see some numbers out here and some concerns about it taking a long time. And that's the data, at least that the Board of Physicians has given me, is that it's 95% within 10 days.
Okay, Dr. Booker and then Dr. Hasselfeld. Oh, did Dr. Booker drop off?
No, he's muted.
Sorry. Thank you for David for the background on that. I think from a practical experience, the collection of those transcripts, the submission of all that data, you know, we've hired someone and we want to get them started. The lead time to do all of that work is fairly significant. And, you know, if you're talking about a telehealth provider who may be, you know, we now, as we try to look for opportunities to fill critical needs in delivery, are retaining providers as they leave our system and move away, or hiring providers in other states to be able to provide services. And so this like back and forth fingerprinting kind of thing is pretty burdensome, particularly since they all go to a federal agency for clearance. It's often challenging. What I do want to say about the collaborative portion, many states have waivers for consultative care, meaning that if someone in the state of Nebraska really needs the expertise of a liver transplant patient at my hospital or at Hopkins, they can reach out and receive that care as long as that local provider is directing the care. But it really still needs to be directing the care of that patient locally. That's generally speaking not helpful for the group of folks that tell us the most, the adolescent psychiatry group who's following their patients off to college, who are not collaborating, who don't really have somebody local. They're really continuing to care for their patient. And most states don't permit that. You need to be licensed in that state. And I think David Sharp, as you pointed out, sort of pivoting to behavioral health. I think much of this is relevant for all of us, but I think behavioral health is really the critical issue that we're talking about here, because that's the big access problem that everybody has. I think, it'd be nice to have more primary care doctors like Dr. Hasselfeld, but I think behavioral health is really the key issue. And there may be opportunities in answering this question: should we alter licensed practitioner requirements to make sure that we're focusing on what the actual need of the people of Maryland is, which is access to behavioral health services. I did want to address one question about apps. And I think the question about apps and online services is many of those companies are cash. And so these requirements around payer credentialing and things like that for insurance purposes, generally speaking, don't apply. And also those companies are well funded and they just license directly. They don't have the difficulty of trying to get a provider licensed in a bunch of places, trying to provide continuity over geographic region, as the majority of health system providers are trying to do, not to have a 50-state footprint. We just want to be able to take care of our patients as they move across our region. And I think those two things are categorically different.
Thank you. We'll go to Dr. Hasselfeld and then to Robin Elliott afterward.
Thanks, mate. We'll just add one more piece to the interprofessional consultation, what I'll call misconception, I think, in these conversations to what Dr. Booker outlined. Many states permit, as Ethan said, us to consult in coordination with another local professional. That is not the same thing as an established patient exception, which is extremely rare. Meaning if my patient's established, I can see them wherever they go underneath some sort of established patient exception. Though, as I'm sure the FSMB will remind us, the FSMB has encouraged consideration of established patient exceptions. They broadly do not exist. So my patient from my Baltimore City practice goes down to DC or Virginia, 60 minutes away. I cannot see them, period, end of story, it's illegal. And that's broadly true most places. And that's what we wrestle with. We would definitely love to understand ways that we can all expand what I'm sure we would all say is very patient-centered. Patients having the ability to see their established providers via various modalities, regardless of where they go, so long as they do maintain a licensure in a state. The second is, why is the IMLC a really poor solution for physicians today, which is a vast majority of our telehealth? 3/4 is subspecialty and 2/3 is physician. So when we're talking telehealth out of Hopkins, we're the quaternary center for the region, delivering oncologic transplant, subspecialty care around our entire region. It is mostly quaternary subspecialty care, well, a good chunk of it being primary care as well, another 1/4 of it. In order to license our clinicians in every state in the compact today, it'd be almost $15,000 per clinician. So, the thought that, oh, we can just get them the compact and allow them to see patients wherever they go is financially disastrous relative to the kind of flexibilities that provides, and really hits on the two key inefficiencies of the compact: cost it retains all of the cost, and then partial implementation. It does solve the third piece, which is accelerated paperwork. That is good, but in order for a compact to be successful, it needs to look like other compacts. Nursing, psychology are very, very similar to being successful compacts. Solve paperwork, solve cost, and be enacted broadly. And the IMLC only gets one of those.
Thank you, Dr. Hasselfeld. I think Robin was next, but I think she dropped off or got disconnected.
No, I'm here on the audio.
Oh, okay.
So I just wanted to raise just a point to maybe be explored later, but I agree that physicians a lot of times have provisions in state law that allow consultation or some temporary arrangement, and they may differ a little bit state from state. But I just wanted to flag that those same types of provisions do not exist for other types of practitioners. So advanced practice nurses or many of the behavioral health providers that we're talking about don't have such provisions. And so just wanted to flag that for any of our future discussions.
And before we move on from that, I think, Robin, that is an extremely important point to note. And I would be curious, again, from the physicians who are on the call today, for their reaction to that very comment, because I think it's very telling of many things, but we've got a handful of really good physicians. I was wondering if you all could just give us your thoughts about that. There's variation in requirements, and do they need to be harmonized? Is that a problem? Is that a chat opportunity? Dr. Ritter?
Yeah, I mean, as a practicing physician and as much experience as I have in this world, I know very little about how to get, licensed elsewhere. So learning from this, I can see that the physicians are going to have to be educated on these pathways, on the different pathways, because it is obstructing our abilities to work, and it is a concern about, doing something illegal is always in the back of your mind, whether you can take care of your college patient in Pennsylvania. But I don't think if you ask the average physician, how would you go about licensing in another state? And this was me. And until I was on the board, I realized about the compact. I didn't know about the compact, and I've been practicing for like 30 some years. So it's educating the physicians in Maryland, and I guess as educating the physicians around the country.
It's a good point. Thank you. Dr. Krakow?
Nothing really else to add. Yeah, it's harmonization would be a very important step forward. I've been intently listening, and let me just add this. Some people have already covered it. I'm just gonna put a foot stomp on some of the opinions that were shared earlier. The compacts, the interstate arrangements, I know that they're well intended. They were an attempt to be the easy button. They're not. It's a lot of work for the physicians. It is difficult to fill out the applications. It is very time consuming. As Dr. Hasselfeld already said, it is expensive. It does not work at all. It is you've really got to be incentivized to go through the whole process. And it is, there is discrepancies from state to state. It's broken badly. Harmonization would go a long way.
Well, very good. Thank you for that. So Dr. Hasselfeld, Dr. Booker, your thoughts?
I think this line of thoughts kind of started with non-physician telehealth. And so I think it's fair to play both sides, that while I emphasize the majority of our care being quaternary physician, a major amount of our telehealth is also non-physician. So I outlined that over the last year, 2/3 of our telehealth was physician, but that leaves hundreds of thousands of visits. We've had 1.6 million completed telehealth visits at Hopkins alone since the beginning of the pandemic. A little over 500,000 of those are non-physician. That is a lot of patient care access across important aspects of healthcare delivery that is certainly as or more important than different areas of physician access. And I think the question really at the end of the day is no different regarding who on the healthcare team is participating in telehealth. That the clinical context between patient and provider of any type is a very specific question. You as a patient, me as a provider, we know each other and we can determine inside of my personal preferences, my scope of practice, what's going to be best for addressing my healthcare needs. And that it does not benefit from kind of over-regulation and restriction. It does benefit from making healthcare connections better and easier. The goal for all of us should be to make connections to healthcare easier, where access is such a big issue. It's not specific to physicians. Certainly empathize and recommend that anything that we say is important for physicians is important for all other provider types.
Very well put.
Yeah, I would echo that. I mean, I think as we all try to achieve, family-centered, patient-centered approaches to care, that's often team-based. And so as a specific example, and this is outward from Maryland as opposed to inward from Maryland, but we have a robust program of advanced heart failure overlapping with our palliative and hospice care groups. And that's a multidisciplinary team that includes not just physicians, but also clinical pharmacists, social workers, occupational and physical therapists. And some of those patients, given that they are very ill, wish to be with family. And so we've had patients who have taken their collected telehealth devices and their left ventricular assist devices, left the state, gone to Minnesota to be with family while they lived out the last few weeks of their life. And they did not want to have discontinuity of the care with the care team that was already provided. We worked really hard with the state of Minnesota and the licensing there, and May, the Connected Care Policy Group and the Regional Telehealth Consortium to understand the policies relative to 4 different occupations, to understand that we could continue to deliver that care. And we were able to do so, but it was a big lift. And it shouldn't be. Right? We should be able to continue that continuity, that team-based and patient-centered approach with a patient who we had delivered very specialized, very personalized care to, who did not want to leave those services. And we had to have a pretty frank conversation about making sure that we could deliver it, or he was going to stay in the state of Maryland and die here without his family. Right? That's the kind of decision we should not have to make. And we didn't have, we wouldn't have been able to take those 4 providers and say, oh, we're gonna go through a compact process to get you licensed in the state of Minnesota on the off chance that one of your patients happens to travel there. I think these are the kinds of challenges that we're trying to deal with. It's different than the question of bringing patients into the state of Maryland or bringing practitioners into the state of Maryland. But I'm sure that there are people coming to visit family in Maryland who have a similar issue, or who are coming to college on our college campuses, who are having an issue with their adolescent provider of behavioral health services that's in Iowa, that they have a relationship with, that they wish to continue. I think bringing it to that level is important.
Yeah, and I think that's what conversation I had with our executive director a short while ago. So it is the exporting of services is what you're essentially saying that's equally as important and has challenges that should be included in any kind of resolution or proposed recommendations.
Thank you, everyone, for that discussion and the reminder that this is multiple professions that we're talking about, and they're not all in the same and equal place here that we need to keep in mind. I'm going to move us on to our last question because we have 20 minutes left, and I know a couple of people had to drop off. So we'll just cover the last question here with our remaining time, and that is, what impact will promoting out-of-state telehealth have on Maryland practitioners? I know definitely I'm from California. There's always a concern of you ease some of these licensure requirements or other requirements for practicing in the state of California. And there is concern by California providers that that would basically increase competition for them. Or, you know, we talked about the concern of like the quality of the services that are being provided to California citizens as well too, but there is also the concern that there will be an impact as well on the providers that currently exist in California too. So what are some of the impacts that people foresee for Maryland if, let's say, interstate telehealth becomes a little bit easier for out-of-state providers? And we have Susan with her hand.
Yes, thank you very much. I'm Susan D'Antoni. I was sorry that I was late to join. I represent Montgomery County Medical Society, which is a professional association for physicians, MDs, and DOs only. As I listen to this conversation, I certainly, as an advocate for all physicians, but certainly with a large base of private practice physicians, am concerned for them for many reasons. I think as we're stressing the importance of a medical home, a physician who knows you, hopefully who can take care of you for a long time, your children, maybe your grandparents, what this does to me is that it upsets that continuity of care. Because as you, as other clinicians are able to treat patients in Maryland, but yet their primary care physician has no idea what has been going on. Maybe the patient doesn't share that, or there's no communication or documentation that is shared through CRISP or otherwise. It makes it very difficult for that primary care physician to really understand all the ramifications of the drugs that you may be on, but that you failed to tell them about. So I think that there is a continuity of care issue. I think there's a communications issue. I think whether or not we require them to somehow or another communicate with their, their medical home, if they're an outside provider, clinician, is an important question. I think also physicians that have other people that are taking care of their patients, but yet don't have the full understanding of what care has been provided, we are increasing the risk associated for those physicians. So when you look at malpractice and you look at, well, is that physician supposed to have been informed of all of those other clinicians involved in that patient's care? And then what if some untoward circumstance or adverse event takes place and the physician had no idea about that? So I do think that those are real issues. I do think competition is an issue. And I think, especially for those private practice physicians, I think for those urgent care, for primary care, for subspecialty care that is practicing in a private setting, that this sort of ability of other clinicians to care for their patients and as I said, maybe do things that they are very capable of doing. When, Maryland is a challenging environment for physicians anyway. In terms of the cost of care as well as the payment from insurers. So I think that this will just add, has the potential to add insult to injury. And we may see even more physicians leaving private practice, going to systems, or actually leaving the state or leaving the profession of medicine.
Thank you, Susan. Anyone else with thoughts on this particular question? And very good point, Susan, bringing up the potential of, are you at risk of malpractice if you weren't aware of like what the patient may have seen somebody else and they didn't tell you about it? Because own personal experience, like you can't, sometimes the patients don't tell the doctors everything. Diana, and then Dr. Booker.
I think so. To sort of provide the alternate viewpoint on workforce in Maryland in terms of providers, looking more broadly than physicians, looking like in general, we are in a very serious situation with our healthcare workforce at this point. Of course, across all different disciplines, and especially hit hard on certain specialties, as mentioned earlier, with like behavioral health being in continuous short supply. It's MHA views interstate telehealth and just continuation of telehealth in general as a way to help alleviate some of the pressures that our workforce are feeling. We've seen a lot with, a lot of help with telehealth as a release valve for provider burnout, to help our workforce do the best that they can, given the constraints that they had. So that's just I'd like to just offer that up as sort of, the way that we've been viewing telehealth and how it could really help get Marylanders access to care that they really need in a timely and appropriate manner.
Thank you, Dr. Booker.
Thank you. Susan, I really appreciate your perspective for the private practice group. And I, have to, my comments are as someone who is one of those large health systems of 3,600 employed providers. So is very much a different one. And we are prepared to be competitive for the services that we delivered. We're in a competitive space already, especially around, as Brian mentioned, the quaternary and subspecialty services that we provide. We are already quite competitive about those. But there is an access problem, as Diana mentioned, for a lot of the services that are fairly routine. And I think that the issue of taking a measured approach to promoting out-of-state licensure for telehealth to make it easier for people in the state of Maryland to get care, whether that's behavioral health or primary care, is likely to promote a more unified approach and not a less unified approach. Right now, those what I would describe as asymmetric competitors, the Amazons, the large vendors that are providing virtual first primary care that are siloed, are primarily coming in as cash businesses and have the capacity to actually license in all these states and take on 1099 employees to do that work that way. And so my perspective is that the current environment, in that it is siloed and somewhat barriered, actually creates some difficulty for health systems that are just adjacent to us. We're looking to establish partnerships with health systems who are here locally or with providers who are here locally. It creates a disincentive that actually makes it more likely that a cash payment business or a national vendor that doesn't rely on the usual mechanisms of licensure locally are likely to further fragment and silo care, and that barriers actually make that worse, not better.
I'll just say ibid for the attorneys on the line. See above. I do think that what we see and feel is that those of us committed to regions through brick and mortar and present practices, those that have served our region for a century and a half, feel that the things that we're worried about are the only ones that can succeed in our current licensure environment. The disruptive potential fragmentation of transactional healthcare are the only types of companies that can take on the infrastructure to license in 30 to 50 states because it's part of the business model. Making the borders of our region easier actually makes it easier for the relationships that exist to continue. So I will just completely agree with Ethan on that. And the other part is, physicians and non-physicians alike, we've all wrestled with the evolution from paternalism to autonomy. Patients get to choose what's right for them if given all of the right information. And I think that this is squarely in line with that. Patient choice, especially in an environment where access is limited across the board, that has to become more and more of a priority. So I'm a primary care clinician, and if a patient chose to go somewhere easier, that's okay with me. I just faxed information an hour ago in clinic, so it's not like we're technically interoperable across the board at this point in time. So I do think that Ethan's comments are spot on.
Thank you, Dr. Booker and Dr. Hasselfeld. Yes, David.
May, thank you. So this may be for a later time, but I think what I'm hearing some of the physicians point out is there's an access issue. And I think what I hear them saying a little bit is this question, we have to look at, how does it affect access? Because that is an area where I think when we think of telehealth, particularly in certain places of the state, it has to factor in. And maybe Dr. Hasselfeld, since you were talking about that, you might also touch on this point.
Sorry, David. On the access piece and how it may factor in. I mean, I think
because there are areas of this, areas of the state. Yeah, go ahead. Sorry.
No, that's okay. I do think there's a core balance. I mean, it's at the end of the day, and many people on the line know I come from a background of economics in addition to then going into medicine. And I'll go to the economic side for a second. It's efficient to get services where they need to be as simply as possible. And that needs to be balanced against the benefits of governance. And so I'm not detracting away from kind of the discipline, safety, and quality aspects of the discussion, which are real parts of the discussion that have to be kind of balanced and thoroughly thought through, but they're not impossible. We can make the process easier while retaining discipline. We can make it cheaper while retaining discipline. So, there is a vested interest in all of us in making the interstate transportation of health delivery services easier and more efficient, and getting those services to where they need to be through the use of technology. So we know in our own system that the addition of telehealth has allowed clinically appropriate indications to get into care more easily, more quickly. We know it's allowed patients who otherwise would have gone without care directly in survey data where patients have told us I would have chose to not go anywhere to be able to get the care that's clearly clinically indicated. And by the way, we have that data out in the public marketplace, both in the New England Journal and elsewhere, that is a real equity access piece in addition to broad access piece. Our data supports the federal data, which is those historically marginally served or historically facing systemic racism from the healthcare industry are the ones that are using telehealth the most. And it creates a new pathway to access into the healthcare industry. We think that's a good thing too. And my clinic down on the water in Canton still has a $15 park, not owned by us, by the way, in $15 a park there. I mean, it's, how hard is it to get into that, to get into my practice if that's the transportation barrier you're going to face? So I think interstate efficiencies are a good thing. I think the equity components to access are as or even more important.
I think one other point, and Dr. Booker, Dr. Hasselfeld, correct me if I'm wrong and I misunderstood this, is that you were trying to make was that some of the checks and balances that we've had in place for a while may not actually be working as efficiently as they could be right now, just given the changing environment, such as you mentioned, the Amazons who can afford just to get a whole bunch of people licensed, but then are not required maybe to relay that information that they've had this encounter with a patient back to like that patient's primary care provider. So while the licensure thing is a good thing, it does provide some protection and everything. You have a player who is abiding by those rules, but that sort of relationship that they have or the information that they need to transmit or are not transmitting kind of creates an environment where, that may not have been like the best way perhaps to like regulate or make sure that that sort of connection with like the information back to the patient's primary care provider happen. Am I understanding that correctly? What you were both getting at a little bit?
Yeah, I think that what our experience is as we, with our respective responsibilities to understand the markets that impact our delivery of healthcare locally is that the cost of doing business includes multi-state licensure for vendor-driven or sort of for-profit companies trying to provide care. They are businesses, and the cost of doing business includes an army of credentialing and licensing assistance to their providers and a business model that allows them to take on providers who are willing to come on as 1099 type employees to those business models. And so the way the rules exist now is the kinds of companies like Lemonade that Dr. Ritter mentioned earlier are able to overcome the existing barriers, whereas system providers that are just over the border in Delaware, just over the border in Pennsylvania, just over the border in Virginia, that are trying to maintain continuity with their patients are actually it's a higher barrier for them because multi-state licensing and this kind of thing is not built into their business model. And for us, continuity matters. So it doesn't matter that we MedStar have other folks licensed in Maryland where I can just hand you off. The continuity is important. So it's me personally that needs to be licensed in multiple places, not our business as a whole, where it's essentially transactional. So I think there's a transactional component that's permitted by the current rules that we would just like to see that barrier lowered to make it easier to provide continuity across the communities. And I think totally separate issue for our existing patients to be able to follow them where they go, which is not really within the scope of Maryland to achieve.
And there's a comment from Lori in the chat. Those models also works in our workforce challenge. They offer much higher salaries than community behavioral health providers can afford, and they aggressively market to our psychiatrists in particular. So they try to poach your workforce as well too.
That's absolutely true, Lori. We are having a very difficult time as a system hiring and keeping psychiatrists because of the opportunities for them to go and work in that model. And so we look at opportunities to contract with folks and bring people in, whether that's a democratic telehealth focused group that we're trying to bring in and provide, and they're going to come through our door. We're going to credential them. We want some streamlining to their process to be able to provide care under our umbrella. That's a way that we would use this flexibility.
Well, I'm going to call for last comments because we are 2 minutes to the hour and want to be mindful and respectful of everyone's time. Right. Well, thank you, everyone. I'm going to turn it back over to Shannon from West Health just to wrap us up and talk about a little bit about the next meeting.
Yeah, thanks, May, and thanks so much, everyone, for this great conversation. It's going to be a fantastic springboard into our future meetings. So we just wanted to put this on your radar that the next meeting will be on February 27th, about a month from today, from 1 o'clock to 3 o'clock p.m. The links are there to register, and we'll also be posting the recording from today's meeting to the Interstate Telehealth Workgroup webpage. The link is there and has also been in the communication that Kelly sent. And in the meantime, if you have any other thoughts or feedback, please don't hesitate to reach out to us, and we look forward to continuing this discussion with you all.
Just a quick call. That meeting will directly overlap with Maryland Medicaid Advisory Committee public comment meeting. So you're going to get everyone getting pulled into two different sessions.
Yeah, we will. Dr. Hessel, thank you. We didn't realize that. We'll reschedule. Yeah. We'll find another day. That's very important. Thank you.
Yeah, thanks.
Great. Well, Ben, did you want to make any closing remarks before we end the meeting?
Thank you. Thank you, Kelly. Really fruitful, productive conversation. I think that Westat and the Healthcare Commission staff will pause over the next several weeks and talk a little bit more about the question that David posed at the start, which I think in terms of some of the feedback, particularly from the systems, is this focused on supply into the state of Maryland, or is it a bilateral both import and export of healthcare services and providers? I think the directional letter from the committee talks about access for Maryland residents to out-of-state providers. But I think the concern that Susan raised about impact on Maryland providers can be resolved to some degree by a focus on what needs to be done to enable Maryland physicians and other non-physician providers to have easier access to patients outside the state as well. That's not as clearly stated in the directional letter from the committees, but one in which I think it's important to balance those two priorities off as we move forward with a constructive solution to both of these challenges. So thank you all for attending. Look forward to the next meeting, which we'll get back to you on very shortly in terms of when it can be scheduled. We definitely don't want to conflict with the MAC meeting on the 27th. Thank you all.